Awesome. Yeah. Again, it's nice again looking back and seeing the transformation of a therapeutic segment like that, and again, hopefully we'll be seeing things like that in SCI in the coming years. Getting to Nirvgen though, and sort of going back to the story which we profiled a little bit in the past, sort of one of the core thesis by Dr. Jerry Silver, who sadly we lost earlier this year, is this principle that our central nervous system does have an ability to repair itself, but there is confounding factors, namely the interesting or intricate ways the scar tissue is laid down, sort of a lot of the inhibitory signals that inhibit that regeneration. And when we look at the spinal cord and some of what Dr. Silver's work has been involved in the last few decades, two really interesting parts to it. One, the scar being laid down with these chondroitin sulfate proteoglycans, or CSPGs, and then the receptors, they ultimately bind to the protein tyrosine phosphate sigma. We'll get to the therapeutic intervention in a bit, but talk a little bit about this nervous system scarring damage cascade, because while our body does it for a purpose, it also prevents a lot of other important things from happening. And I'd like you to take us back into that story a bit, if you would.
Let me take you a step back a little bit farther from that, because, as a physician, and then even into an ophthalmologist, we as physicians were always taught that when there is damage to a neuron within the central nervous system, that there is no chance that neuron is going to regenerate or repair itself. We can see this in retinal diseases where there's neuronal damage in the peripheral retina. We can see it in optic nerve diseases, such as glaucoma, where once the nerve is damaged, you're just preventing further damage to the nerve. There's nothing that we can do to repair the nerve at all. And so when I was introduced to Jerry Silver and his papers and getting interested in Nirvgen, this is back in 2022, I was reading Jerry's papers. I was watching his lectures and some of his hour-long seminars on YouTube. And I read his papers over and over, and I watched the videos over and over. And I still watch them today because obviously seeing our clinical results, I go back and see the correlation to what Jerry was discussing sometimes 9-10 years earlier. And, Jerry was really the first physician, not the physician, but the first person out there that actually said, look, neurons can regenerate. We were all taught neurons do not regenerate. And Jerry stuck with it, and he kept, evaluating this and looking at the science and determining what was going on and how do we get past these chondroitin sulfate proteoglycans, which you call the scar, how do they get around it? So that's really where we are today. Is we're at a point where what Jerry envisioned the world, that we could get neurons to regenerate or enable the nervous system to regenerate itself or repair itself. We're at the precipice of that, I believe, with Nirvgen.
And continuing along those lines, ultimately, we have this CSPG PTP interaction. So, when that scar tissue or those, proteoglycans bind with the receptor, you get a microenvironment of sorts that inhibits regeneration, inhibits neuroplasticity. And ultimately, what the company came up with is a lead candidate known as ISP, which stands for intercellular sigma peptide, a synthetic peptide that ultimately was developed to inhibit the protein tyrosine sigma receptor and allow the proper signals to go through and prevent the inhibitory signals. Take us into the world again of ISP, what it does, how it was developed, because this is
so obviously Dr. Silver determined what was holding back the neurons that were damaged, and so that's the CSPG in the extracellular matrix of the central nervous system. It took him many, many years to identify that. And then around 2009, Dr. Silver and his lab identified PTP sigma and how PTP sigma interacts with chondroitin sulfate proteoglycans. And then he spent the next few years determining, all right, how do you interact, or what drug can we introduce that's going to interact with PTP sigma, that's going to enable these neurons that are basically being capped by the CSPG. How are we going to allow those neurons to continue to sprout and grow through the CSPG or around the CSPG, the scar, so to speak, that you're discussing? And that's what Jerry discovered. He discovered how that worked. And amazingly, we administer that as a subcutaneous injection on a daily basis, very similar to how anyone would give themselves insulin or give themselves Wegovy or Ozempic, that's very popular today. And we give it as a daily treatment for 12 weeks in clinical trials right now.
And that, so that takes us up, I guess, to the current clinical trial. And obviously before that, and again, we've talked a little bit about in previous, he did a lot of work in animal models, which showed the improvement, walking, bladder control, vision, memory, because he looked at other things on SEI. You did the phase 1, healthy volunteers, very safe, very tolerable. Take us through, the recent data that came out is all about the phase 1b/2a study, where you looked at both acute or sort of subacute injury and chronic, which, we have to distinguish here because, two different populations, but with different challenges, but nonetheless quite intriguing that, you have opportunities for NVG 291 in both sets. But take us a little into what the results were, what you found in this study, met both primary and secondary endpoints, and I'd like you to take a little time to walk through, electrical conductivity and so forth.
Yeah, let me take a step back to the animal studies that you discussed, Ira, first, because I think the animal studies, when I got interested in NeurVgen and first became involved, I think the animal studies were very, very interesting, and I think anybody who's interested in NeurVgen or nerve repair should take a look at some of the early papers. And what's amazing is, a lot of times you'll have one lab is able to produce data alone. Right. It's not just Dr. Silver's lab that was producing data. It was multiple labs around the world that were replicating his data. And that's the first piece of information to me was, all right, it's not just this guy, Jerry Silver, up in Cleveland, Ohio, who is able to do who can only do these studies and get these results in his hands. It was being done in many different academic labs around the world, out in Germany, parts of the United States, over in China, and, both in spinal cord injury and, as you said earlier, in stroke. And then what you see, and then Jerry did it Dr. Silver did it not only in acute model, but he did it in a chronic model as well, where he treated rats, and I forget the exact data, but I want to say it was 3 months after the injury, and then he treated them for the pre-specified time, and then he continued to follow them even after treatment, and he continued to show improvement. And to me, his early studies, whether you're looking at the Petri dish where he is showing growing of the nerve, where there's CSPGs in the Petri dish, and he's adding, at the time, as you said, ISP, and showing the neuron grow through the CSPG, or whether you're seeing the animals start to regain hind leg function, tail function, where they're actually lifting up the tail, lifting up their hind legs, then walking across the ladder. We are seeing very similar results in the human studies in the phase 1b/2a. I think this is one of the few instances in a drug company where I can tell you the early clinical models really translate to what we're seeing in the human phase 1b/2a, what we call the Connect SCI study. It's really two studies in one. We've got subacute, which is up to 6 months, and then we have an acute arm, or a chronic arm, I apologize, which is 1 year to 10 years. The chronic arm is finished. The acute or subacute arm is still recruiting for the Connect SCI study. So we can talk about the Connect SCI study results
Please.
that are available today. It's one of the few drugs that I've seen for spinal cord injury that has been able to improve both upper limb and hand function in individuals. So let me just take one step back too. So the study was a 12-week study. Individuals had to have C7 or higher injury, and it was motor incomplete, meaning that they still had some connection between the brain and an organ, meaning the muscle here in this case. So they still had some ability to fire an electrical signal from the brain out to their muscle. Those are the individuals that qualified for it. They were 18 years and older. Spinal cord injury is a bimodal distribution. You get very young individuals around 20, and you get older individuals around 65. Obviously, as you can imagine, if you're younger, it's from more of a motor vehicle accident or sporting event. Older, it's usually from a fall. The average age of individuals with spinal cord injury is somewhere in the early 40s. And that's basically what we saw in this study. We then we had two arms: 10 individuals in the treated arm, 10 individuals in the control arm. All of them got physical therapy 5 days a week, and it was at one single site in Chicago, the Shirley Ryan Ability Lab. The treatment arm got NVG 291 on a daily basis for 12 weeks, so 7 days a week for 12 weeks. The control arm was administered a placebo injection, and after 12 weeks. The drug discontinued, the physical therapy continued as well, and then we continued to measure at 16 weeks as well how the individuals were done. I can't discuss that at this stage, but at a later point when that's all public knowledge, we can discuss it. But what we found was a 9.3x improvement in hand function versus placebo, and a 2x improvement in upper limb function versus placebo. These are secondary endpoints. The primary endpoint was electrical activity, either in the upper extremity, meaning from the neck down to the first dorsalis interosseous, which is right here, and then or electrical activity, which was a little bit started farther in the mid-back, all the way down to the tibialis anterior, which is the muscle, which is, if you feel, it's right next to someone's shin.
Right.
We hit the primary endpoint in the upper extremity. We only needed to hit either the upper or lower MEP, which is the motor evoked potential. We did it in the upper extremity. And when you do that, when you separate the two co-primary endpoints, you have to have a p-value that's below a 0.05. So we had to hit a 0.025, and we did that. We hit 0.0155. So it was very statistically significant for the upper extremity. And then, as I discussed before, we have a 9.3x improvement in hand function, and specifically in something called GRASP, GRASSP, which measures very fine hand movements, such as putting a key in a lock, picking up a glass of water, pour it in the glass of water, and then bringing it to your mouth, putting a nut on a bolt, putting pegs in a 9-hole peg test. So these are very, very, they utilize both fine movement and more coarse upper arm movement to get these done. And those were very strongly positive in these individuals. And so as we move forward, we feel very strongly that individuals with this are gaining significant functional improvement from the use of NVG 291. So we feel strongly that we are having a biological effect.
Absolutely. And again, and we talked a little about this in the past, the numbers here, when we just look at the United States in terms of not just the annual healthcare costs, which are in the billions, but when you put on top of that the indirect, the unemployment, someone's chance of bankruptcy, and so forth. I mean, the numbers skyrocket, and this is a clear unmet medical need, major costs involved. What happens next here? Because clearly you're on the precipice of some really important results. I think you have an FDA meeting coming up at some point, but if you could take us a little sort of what the vision is next in terms of whether it's the subacute, the chronic patients, where does this all go at?
Well, our mission for Nirvgen is to not only, our mission is, if you read my email, be improve the lives of individuals with spinal cord injury. Mm-hmm. I almost think we should transcend that to be transform the lives of individuals with spinal cord injury. I got into this job and I got into this company for the sole purpose of improving people's lives. I saw an enormous unmet need. I was actually not reprimanded the other day. I used the term underserved community, meaning the spinal cord injury. It's actually not underserved, it's unserved. There are no biologic drugs, there are no pharmacologic drugs, I should say, out there available to anyone with a spinal cord injury. So if you come in the emergency room, you've had a traumatic spinal cord injury, they're going to medically and surgically stabilize you. You're going to go into 6 or 8 or 12 months of physical therapy rehab. And then basically it's symptomatic treatment for the rest of your life. And if you're highly motivated and have the funds, you can continue on physical therapy, but many don't. And so there's really nothing else that we can offer individuals with spinal cord injury in the medical community today that's going to improve their connectivity of their neurons to give them more function. Anything would be an enormous improvement for these individuals. Just the mere fact of hand function, being able to grab a fork and feed yourself or pour yourself a drink of water, is an enormous benefit to individuals with spinal cord injury. It gives them independence. It allows them, you said there was a high unemployment rate. It gives them the ability to use their mouse or type on a keyboard. And we're not even talking about, I can't even get into the lower extremity functions as far as improvements there, which we can talk about at a later date. But, there is just nothing out there for individuals right now. So our mission is to bring NVG-291 to market. Our mission is to improve the lives of individuals with spinal cord injury. And, the next year, what I foresee is us starting a large phase 3 clinical trial to bring this drug to market so that individuals with spinal cord injury can benefit from NVG-291 and improve their lives.
Excellent. Staying on NVG-291, but moving away from spinal cord injury for a minute, I couldn't help, not see the recent press release in terms of your work with the Department of Defense. And it's kind of interesting that just last month I had one of my guests was Colonel Tanya Roy from down at USAMRIID, and her area of research was blast overpressure and sort of this amazing change in atmospheric levels when there's an explosion, which can cause everything from hearing loss to traumatic brain injury and everything in between. I couldn't help but notice that you're seeing some really interesting results in your collaboration and as preclinical with the Defense Health Agency. Can you say just a couple words about what you're working on there? Because I think it's, again, another interesting piece that shows sort of the diversity of this compound and potential applications beyond, SCI.
Yeah, well, it's interesting because I got into Nirvgen because of the spinal cord injury component of the drug, and I really, really wanted to, and I really got into this for a humanitarian reason of I wanted to bring a drug to market that would help people that had nothing. And the longer I've been in Nirvgen, the more I look at NVG-291 and the more I look at our company Nirvgen is really a company that's treating neurotrauma. And that's really where I see this company going. And it's not just spinal cord injury. As you said earlier, you brought up stroke, cerebral vascular event, whether it's ischemic or non-ischemic. We have very good preclinical data in animals, rats and mice on that. But we have very solid data in blast hearing loss, which I would say spills over into traumatic brain injury. And that's really what that blast injury is. It's neuronal damage that is, TBI. And TBI is another enormous market where there's really no treatment. We all know people that have had concussions, and we call it TBI now. But I am very excited about the possibility down the road of traumatic, whether it's hearing loss, traumatic brain injury, or stroke. There's a much bigger picture here than spinal cord injury in and of itself is enormous. As you were alluding to, it's a large market. In the United States, it's 300,000 individuals alone. And then you start adding on TBI, traumatic hearing loss, and stroke, you really get into a huge possibility for NVG-291 in the future.
Yeah. What should we be on the lookout for in terms of you for the rest of the year? I mean, I know you've taken on the CEO role recently. Conferences, whether they be science, investor related, other public facing initiatives out there where we may be able to run into you, meet you at some point. Anything else on the calendar that I did not bring up today that you want to mention, please? I'm
going to be at a number of different events over the year. I cannot, to tell you the truth, I don't remember all of them. They've packed my schedule, but my goal as the CEO is to be forward facing, get the message of Nirvgen out. We're obviously going to start a phase 3 study next year for chronic spinal cord injury for individuals who have had the injury from 1 to 10 years. And keep my number one mission, and I'm a very mission-driven individual, is really not just to give lectures and get up on podiums. It's really to get this drug to market into the hands of the people that really need it, and it's going to improve their life. So that's really where I'm going to be spending my next 6 to 12 months, is making sure that we have a successful launch of NVG-291 for our phase 3 study.
Excellent. Well, it's an awesome mission. It's a great company and product, and I enjoyed covering it the first time. I enjoy seeing how it's being further developed, and again, I'm glad you're leading the company now, and I look forward to continue following up. Hopefully, do episode number 3 next year when you get into phase 3. But really impressive work and a great story. Again, for everybody out there that is going to be listening to this episode across the podcast networks, or who will be watching on the YouTube channel, again, you've been spending time with Dr. Adam Rogerz, the Chief Executive Officer, Nirvgen Pharma, doing really amazing work to develop these innovative treatments for traumatic brain injury, spinal cord injury, ischemic stroke, and many other conditions. Adam, I want to thank you for taking the time to come update us on everything you're doing there. Again, thank you for what you do. And, as we say on our show, thanks for helping to create a better tomorrow for millions of patients out there via what you're doing. Really.
It's my pleasure, and thank you for your time this afternoon.
Great having you.
All right.